Okay, atherosclerosis. So the atherosclerosis is basically the hardening or narrowing of the artery, right? So it is a hardening or narrowing of the artery, right? So what is the initial initial injury that initiate the process of the atherosclerosis? It's again a high yield. It is endothelial dysfunction. So this is the normal, this one, right? So here, this damage endothelium is a key thing that initiate these pathological changes. After this injury, it is followed by the macrophages. So what will do these macrophages? These are right. So when these macrophages engulf the LDL, high yield, engulf the LDL, these macrophages converted into foam cells. When they engulf, macrophages are monocytes are the same thing, right? So first initial injury is endothelial dysfunction, or you can say that endothelial injury, right? And and this foam cell is a macrophage that engulfs the LDL. So foam cell formation lead to the fatty streak. So this is a fatty streak, right? So lipids, macrophages, and foam cells. Lipid-laden macrophages, foam cells, and this is a fatty streak. Okay. So after this fatty streak, what happens? This smooth muscle cell migration take place. This smooth muscle migration takes place. So what happens? The smooth muscle migration takes place. So they proliferate. This smooth muscle migration and the proliferation take place. So this thing, right? And after that, the smooth muscle migration, then the extracellular matrix deposition. This extracellular matrix deposition lead to the formation of fibrous plaque, and it will lead to the formation of the complex atheroma, right? So the complex atheroma undergoes the calcification, right? Complex atheroma undergo the process of the calcification, right? So calcium contained correlate with the risk of the complication. So in MI, what happened? The pathophysiology is atherosclerosis plus this fibrous plaque rupture. It will lead to the formation of thrombus and it will occlude the coronary artery, right? So again, this is first USMLE love to ask the which of the following is the initial injury. So it is an endothelial dysfunction. Which of the following things correlate? Which of the following things increase the risk of the complication? So it is a calcium, right? So the calcium deposition determine the risk of the complication, while the initial injury is endothelial dysfunction, right? In many ways, they ask about these things. What is the most common risk factor for the atherosclerosis is hypertension. What is the worst risk factor for the atherosclerosis is smoking, diabetes, mellitus, and smoking. These are the worst risk factor for the atherosclerosis, and hypertension is the most common. Okay. So the risk factor divided into the modifiable and non-modifiable is the increased age, male sex, post-menopausal status, because estrogen is a protective, right? So that's why it is in male it is most common. family history, where certain conditions like hyperlipidemia, and these are the modifiable hypertension, tobacco smoking, dyslipidemia, and diabetes. Okay, so this is a location. The most common location for the atherosclerosis is abdominal aorta. So this is a mnemonic, a copycat named Willer. A for abdominal aorta, C for the coronary artery, C for the coronary artery, P for popliteal, and CA carotid artery. So and villus. So you have to cram this mnemonic as well, right? So atherosclerosis is again sometimes they ask about atherosclerosis is a disease of which vessels. So it is a disease of elastic artery and large and medium sized muscular arteries. Okay, let's move toward the complication or histopathology of the myocardial infarction. Okay, so these are the high yield complication of myocardial infarction. So how they ask in the exam, right? So in exam, they give you the time frame. So this time frame is again high yield, right? So they give you the time frame and they want to know the morphology that take place at that time frame, right? Okay, so let's suppose they give you the time frame, ST segment elevation, time frame is less than 24 hours. They want to know that which cells are infiltrate the myocardium. So the first cells are which cells are neutrophils, right? And sometimes they give this kind of the picture as well. So there are a lot of morphology picture, but how do you identify? By knowing the time, right? Okay, so what is the most common cause of death in myocardial infarction? It is due to ventricular arrhythmia, right? Okay, sometimes they give you this time frame again and they want to know the cardiogenic shock arrows. We already discussed what happened to the cardiogenic shock. Cardiac output increase or decrease, cardiac output will decrease, right? Cardiac index will also decrease. What happened to the SVR in cardiogenic shock? This is a high yield concept. It will increase or decrease?
Increase.
Increase. What happened to left ventricle and diastolic volume? It will increase or decrease?
Increase.
Increase. So knowing these time frame and knowing the complication and its morphology is a very high yield, right? And the which kind of the necrosis take place in the myocardial infarction? It's a
Coagulative.
coagulative,
Necrosis.
coagulative necrosis. In coagulative necrosis, the architecture of the cell is preserved or not?
Can you repeat? Your phone broke up.
I say that in myocardial infarction, the necrosis is a coagulative necrosis. So in the coagulative necrosis, the architecture of the cell is preserved or not? I'm asking question to you.
Preserve it. Preserve it.
Preserved.
It
This
is
is
still preserved.
again high yield. and the reperfusion injury. What is the reperfusion injury? When you reperfuse, when you when you reperfuse this patient, what happens? Free radicals, free radicals and calcium influx take place, and this will lead to the hypercontraction of myofibrils, right? Knowing the time frame, knowing the cardiogenic shock, it is a very important, right? Okay, if they give you the scenario, this kind of 0 to 24 hour, and they not give you the diagnose, they give you the arrows, this kind of the arrows, right?
Okay.
Okay, so pericarditis. So the pericarditis is two types of pericarditis take place in a myocardial infarction. Can anybody tell two type of pericarditis? One is peri-infarction pericarditis. It is also known as a PIP. Another is Dressler syndrome, right? Dressler syndrome. Okay. So Dressler syndrome is due to
Autoimmune.
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 They want to know the mechanism. Dressler syndrome is autoimmune, right? Because
Okay.
antibodies are produced against the cardiac cells. What about the peri-infection and PIP? So the time frame of the PIP, peri-infection pericarditis, is 1 to 3 days, right? What about the Dressler syndrome? It's weeks to months, right? Again, the high yield point about the peri-infarction pericarditis. What is the if you early reperfuse the cardiac tissue, the pericarditis risk will be the decrease. So the early reperfusion decrease the risk of the pericarditis, particularly the peri-infarction pericarditis, right? Okay. So during this post-infarction or fibrinous pericarditis, which is also known as PIP, peri-infarction, peri-infarction pericarditis, PIP. So, so this surrounding infarct show the acute inflammation with neutrophils abundant. Okay, so this PIP is due to localized inflammation. The mechanism of this localized inflammation due to transmural infarct. So ST segment elevation cardiac infarction increase more likely risk of the pericarditis, right? While the Dressler syndrome is due to the autoimmune pericarditis, due to the antibodies produced against the myocardium. So knowing this time frame is a very, very important, right? Okay, again, this 3 to 14 days. 3 to 14 days. So pre-wall rupture. Pre-wall rupture lead to the tamponade, right? So in tamponade, can anybody tell me what happened in tamponade?
Obstructive shock.
Okay. So which triad is present in tamponade?
We have the best triad. So you have jugular vein distension, muffled heart sound.
Okay. So the most important is this kind of the back triad and papillary muscle rupture, right? So it will present with mitral regurgitation. They give you the scenario, like let's suppose that 70-year male with typical symptom of heart failure. 1 year back, he has history of the myocardial infarction, right? And he present with hollow systolic murmur. Hollow systolic murmur at apex that radiate to axilla. So it is so that the patient has myocardial infarction, and this myocardial infarction lead to the mitral regurgitation. Okay, but they ask in mitral regurgitation, what kind of changes take place? Which kind of hypertrophy take place in mitral regurgitation?
Eccentric.
Eccentric,
Dilated.
dilated cardiomyopathy, right? Eccentric. Okay, so this is again the tamponade and mitral regurgitation, the most high yield stuff. One more thing, in 3 to 4 days, so macrophages infiltrate, while in 1 to 3 days, still neutrophils are present because the neutrophils are abundant or they are the cells of the acute inflammation, while the chronic inflammation cells are macrophages and okay. So again, interventricular septal rupture due to the macrophage mediated structural degradation, left to right shunt. So left to right shunt, why it is left to right shunt? Because when this, let's suppose this red color, this is interventricular septum, interventricular septum. So if this rupture takes place, so the left sided has higher pressure. So if rupture, so blood move from left to right because left side has higher pressure and blood move from higher pressure to lower pressure. So that's why interventricular septal rupture left to right shunt take place and left ventricle pseudo aneurysm. So it will again the risk of rupture, pseudo aneurysm, dilatation. Aneurysm means dilatation. It is not true aneurysm. So pre-wall rupture lead to the tamponade, papillary muscle lead to the mitral regurgitation, and interventricular septal rupture lead to left to right shunt. Okay, from 2 weeks to SVSD. VSD, which the shunt is left to right or right to left? It's a left to right.
To right.
So again, it's
Left
left
to
to right. Right. Yeah, you are right. Okay. So in 2 weeks to several months, 2 weeks to several months. So can anybody again tell me the post cardiac injury syndrome? So this is another name of which syndrome?
Dressler syndrome.
Dressler syndrome. So what is the mechanism? The mechanism of the Dressler syndrome, again a very high yield. Dressler syndrome. Its mechanism is autoimmune.
Yes.
Okay. So again, the repetition risk of the mural thrombus. So 2 weeks to several months, the most high yield complication is Dressler syndrome, right? Okay. This is again the duplication of the myocardial infarction in detail. So cardiac arrhythmia. So which arrhythmia is the most common? Is ventricular arrhythmia, right? And what is the mechanism of this cardiac arrhythmia? What is the mechanism? Is basically scarring due to myocardial infarction, right? So important cause of death before reaching the hospital within first 48 hours. So this arrhythmias is an important cause of death within first 48 hours because of scarring. If they give you the scenario, the patient die on the way of the hospital. So they like what is the pathophysiology of this death? So it is scarring of the myocardium, scarring of the myocardium. So this is again peri-infarction pericarditis. We already discussed this PIP, right? So increased risk is 1 to 3 days. So it is a typical present with a pleuritic chest pain, pericardial friction rate, ECG changes. What are the ECG changes in the pericarditis? ECG changes in the pericarditis.
SCT wide SCT segment elevations in all leads and shortened BR interval.
Okay, so diffuse ST segment elevation.
Yes, diffuse SCT segment elevation.
Okay, so it's usually self-limited, right? So which thing decrease the risk of the peri-infarction pericarditis is early reperfusion, right? You may give high dose aspirin as well, but avoid corticosteroid and NSAID. Why? Because they increase risk of pre-wall rupture. So increased risk of pre-wall rupture may lead to cardiac tamponade. So the cardiac tamponade is again emergency situation. Okay. So papillary muscle rupture. Papillary muscle rupture lead to mitral regurgitation. The most high yield papillary muscle rupture. Okay. So it lead to acute mitral regurgitation, cardiogenic shock, and pulmonary edema. So the pulmonary edema patient present with on auscultation, I think is bibasilar crackler, bibasal crackle. Am I right?
Yes,
So they give you on the auscultation.
fine crackles. Yes.
Okay. So the the posteromedial papillary muscle has a single artery blood supply. This is again high yield, where the inferior lateral has dual blood supply. So this is again very high yield, super high yield. So again they give you the holosystolic murmur in the exam at a apex, give you some kind of the future of the cardiogenic shock as well or MI, and they want to know about what is the cause of this problem. So again, so posterior medial has highest risk. Why? Because the posterior medial has a single arterial blood supply, which is a PDA, right? while the interior-lateral has a dual blood supply, left anterior descending and left circumflex, right? So that's why there is a less chance of interior lateral muscle rupture or infarct, while there is increased chance of the posterior medial infarct. Why muscle? Because it has single blood supply. So we already discussed about the interventricular septal rupture. Which kind of the shunt take place? Interventricular rupture, left to right shunt. So left to right shunt. We already discussed why left to right shunt, because the left side has higher pressure as compared to right side. So that's why interventricular septal rupture leads to left to right shunt, right? So what happens? Increase O2 saturation. If again, this is again, sometimes they give you again. We already discussed about the O2 saturation. So what happens in O2? SpO2 in VSD, in right ventricular and pulmonary artery. Increase or decrease?
Increase.
Sorry?
Increased.
Increase. Why increase?
Because left to right shunt, left oxygenated to the right.
Because left-sided oxygenated blood comes to the right side because of this shunt, right? So the right ventricular and pulmonary artery oxygen saturation will increase in VSD, whether it is a congenital anomaly or whether it is a complication of the myocardial infarction. So again, the time frame is 3 to 5 days. Time frame is 3 to 5 days, right? So what is it is a macrophage mediated degradation, right? Okay, so the ventricular pseudoaneurysm. So the time frame you have to cram this time frame. Okay, so it may present like chest pain, typical heart failure type symptoms, and this if this aneurysm rupture takes place, it will lead to cardiac tamponade. So this pre-wall rupture and both of these lead to cardiac tamponade, right? So it is a simple aneurysm. It is a pseudoaneurysm. No need but only the need about you have to need that it lead to cardiac tamponade if it is ruptured. It does not contain endocardium and myocardium. So that's why it is pseudoaneurysm. So true aneurysm contain all layers, while it lacks these layers, endocardium and myocardium, right? So again, we already know that ventricular pre-wall rupture lead to cardiac tamponade. And you know the how cardiac tamponade present, back triad, right? So you already know that the what is a back triad. Okay, so true ventricular aneurysm. So true ventricular aneurysm contain all the three layers, epicardium, endocardium, and myocardium, right? But but the highly chance of the true ventricular aneurysm in 2 weeks, 2 weeks to several months, right? Post-cardiac injury. Post-cardiac injury syndrome, another name is Dressler syndrome. and this mechanism is again our high yield. We already discussed about this mechanism, but this is again cardiac antigen release after the injury and deposition. So simply they sometimes they give you the autoimmune, antibody mediated, antigen mediated. So these are some similar words we found in the Q banks and the assessment questions, right?